Yes, ma'am. We'll wait for 2-3 minutes more and then we can begin.
All right.
Ma'am, participant link is totally different, ma'am. In speaker link, only we can able to log in, ma'am. We can start the session.
Okay, I just wanted to confirm, ma'am, there are two links, one for speaker link and one is a participant link. So at the current link, you won't find any participants. It's only for the speakers.
Okay.
So if you allow me, then we can start. I will, as per your guidance, ma'am.
Yes, let's start.
Okay, ma'am. Thank you. So, good evening, everyone. Good evening, Dr. Nikita Lad ma'am and Dr. Anuranjita Pallavi ma'am. Thank you for joining today's webinar, and it's my honor to introduce Dr. Nikita Lad ma'am. Ma'am is MBBS, DGO, FCPS, FRM, and MRM. Chief IVF Consultant at Apollo Fertility, Navi Mumbai. Director of Baby for Real IVF, Juhu, Mumbai. Ma'am's special areas of interest are high-risk obstetric cases, infertility, hysterolaparoscopic surgery, sonography, and IVF management. Ma'am has many papers published and also a member of various prestigious medical associations. Ma'am's today's topic of presentation is recurrent implantation failure. Our second talk is by Dr. Anuranjita Pallavi. Ma'am is MS in DTO, IVF and fertility specialist, Apollo Fertility, Navi Mumbai. Ma'am is gold medalist in OPS from Mumbai University. And Ma'am will deliver her presentation on oocyte cryopreservation. So with this, may I request Dr. Nikita ma'am for her talk. Thank you very much.
Thank you, and hope everybody's doing good in this time. Now, like you all know, the second wave is again in. Everybody should please take care of themselves. Today I'm going to talk to you all on recurrent implantation failure. And as we all know, this, one second, it's just not moving to the next slide. You know, recurrent implantation failure is very tough to handle, because as tough the thing is, the patients want the answers. Even we as doctors, it's very tough to get the results. What is the reason for failure when the patient keeps failing 3 times, 4 times, and when there are no answers, when we do all the investigations, all the treatments, go to the evidence based management, and what else can we do? So I'm going to try to tell you all what does the evidence say, because as you know, everybody tries to try to put this medicine, that medicine. So what is evidence and what should be done?
Ma'am, sorry to interrupt. Can you do the presentation mode?
As we all know that
that's the left-hand side presenter view is there. Hello. Doctor, you have again share your screen and you're on mute, so we cannot hear you.
Yeah, I'll just let my internet, there was a little weak connection.
Okay.
Now can you all hear me?
Yes, ma'am, we can hear you.
Screen share. Can you hear me?
Yes, ma'am, we can hear you.
Well, give me a minute. I'll just start the presentation.
Sure, ma'am.
Okay, like I was
Yeah.
saying, recurrent implantation failure is a difficult topic, a difficult way to handle the patients, and there is no universally accepted definition. Some people say, previously we used to say, when you transfer the best 9 embryos and that doesn't give you pregnancy, then I would call it as a recurrent implantation failure. But now the recent one is no more than 3 embryos if you transfer and they do not conceive in 3 cycles, that is even a blastocyst single blast, then you're known as a recurrent implantation failure. So failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40 years. Etiology, what can be the cause of recurrent implantation failure? There can be 3 things. One is the uterus, that can cause the endometrial receptivity decrease. Embryonic development, that is whether the oocyte and the sperm, both of them cause any problem, and multifactorial. So what is the endometrial receptivity? We have to do a good 3D sonography, find out whether there is a septum, fibroid, polyp, hydrosalpinx, adhesions. If any of this, go for a hysteroscopy, laparoscopy if required. Endometriosis, that I'm going to tell you, when the cyst is between 4 to 6 centimeter, you have to operate, and depending upon the AFC, adenomyosis. Thin endometrium, very tough because we don't know the definition of thin. We've got results even in at 6 mm, and even when the endometrium is more than 14 mm has also given us results. Endometrial microbiota, very common when there is infection in the endometrium. That also does cause some problem in conceiving. Immunological factors and thrombophilias, altered expressions, defective embryonic development. Main thing is when you have a good quality embryo, that's going to give you the result. That's the oocyte and the sperm quality. If that is good, you're going to get a beautiful embryo. If you transfer it right, you have to get the results. Genetic abnormalities, zona hardening, sperm abnormality. Multifactorial will be suboptimal embryo transfer. Sometimes it's so you've got a beautiful embryo, but you've not transferred the embryo right. That's also going to cause implantation failure. So transferring ET, embryo transfer, is a very important step, which is not more spoken about it. Implantation failure, molecular mechanism. So what happens in endometriosis? I'm going to go to the next slide because I'm kept it detailed. Thin endometrium, there is no agreement has been reached on the endometrial thickness. Available evidence does not support any specific cutout. Pregnancies, we've seen pregnancy, like I said, 6.2. There are some evidence showing 5 mm to more than 15 mm have been reported with showing results. What can be the etiology of thin endometrium? Surgically, when they have operated because of adhesions, radiotherapy, infections, prolonged OC pills. Sometimes, patients are on OC pills for a long time. You have to give them a break and the endometrial will grow. Congenital Mullerian anomalies and idiopathic. What about the endometrial infection? Lactobacillus is the predominant endometrial microbe, followed by the Gardnerella. Non-lactobacillus dominated microbiota correlated with adverse reproductive outcomes. Immunological factors, 3 main important aspects are the Th1, Th2 balance, natural killer cells, and autoantibodies. At present, the association between autoantibodies and ART failure remains a controversial issue. Altered expression of adhesive molecule, local dysregulation of normal expression of action of cytokines can cause implantation failure. Elevated levels of natural killer cells, dysregulation of interleukin 12, 15, 18, low IL-10, high levels of aromatase P450 mRNA, changes in the pinopoids expression, and high matrix. So we have to investigate and figure what is the problem. So what are the main investigations which nobody should miss out? In endocrinology, you will do the thyroid sugars, HbA1c, ovarian reserve assessment. Anatomically, like I said, a good 3D sonography will give you a good answer. You can go ahead with an HSG, diagnostic laparohysteroscopy. If something is seen on a 3D, go for a diagnostic laparohysteroscopy. Immunological investigations, anticardiolipin antibodies, lupus anticoagulants, antiphospholipids, thrombophilia profile, histological examination, endometrial biopsy. Karyotyping of the parental cytogenetics, endometrial receptive era is the new thing. When you don't know, you can find out which time is the best time to transfer and DFI. So what does the evidence say? So now how do you go about it? Like I said, the maternal factors, and the embryological factors. So embryonic factors. So what is the anatomical? Like I said, go for a septum, do a septoplasty. You see a fibroid which is interfering and pushing, indenting into endometrial cavity, operate that. Adhesion seen, do an adhesiolysis. Hydrosalpinx, operate it. What about the endometrial thickness and receptivity? So we all add, aspirin, sildenafil for the blood flow, high dose estrogen treatment. Sometimes I've seen patients on estradiol validate taking four tablets, but I have seen when you stop everything, give them a break, you will see the endometrium growing really well. So sometimes if the endometrium is not growing, don't keep increasing the dose. Just take a break. Just stop it. And you can use GCSF. Thrombophilias, we always give low molecular weight. Heparin and corticosteroids, aspirin. Intralipids, IV immunoglobulins. What about the genetical factors in embryonic? So we go for a blastocyst culture, assisted hatching. Sequential transfer gives us good result. Co-cultures, male factor, you can do an MC. For improving endometrial receptivity, correction of the anatomical factors, hysteroscopic correction of the uterine cavity, removal of the fibroid and polyp, laparoscopic clipping of the hydrosalpinx and adhesiolysis. Endometrial injuries to increase the endometrial receptivity. Most of us do a lot of endometrial biopsies or even just take a EB curate and just cause a little bit of injury in the endometrium. That causes good thickness in the next month. Cellular mediators, you can use IV immunoglobulins, GCSF, intrauterine PRP, intrauterine HCG, heparin. You can try all of them. The new kid on the block is this. Management, like I said, the anatomical factors, polyp is seen, please remove polypectomy first, uterine septum, remove the septum. And if there was a big septum, put in a balloon catheter. I've seen a lot of times when we've done the septoplasty and again there is adhesions. So you need to put a balloon catheter or an IUCD, and the next month again you can go and have a relook. Myomas, you do a 3D fibroid mapping, find out where is the myoma. Is it going to interfere our pregnancy? Depending upon that, sometimes if you have the time, you can try uriplastol or just go ahead with a laparoscopy myomectomy. Adhesions, infertility, you can see a lot of adhesions seen, Asherman syndrome, very tough to conceive. In these cases, sometimes we've done 2 times, 3 times hysteroscopy, cut off, remove the adhesions, create the uterus for a hysteroscopy, and after that, do a sharp dissection. Use the scissors to cut more than quartry, and put in post for a balloon cat. You can have a relook hysteroscopy. Hydrosalpinx, always, like I said, remove. Hydrosalpinx is there because the mechanical flushing of the cavity with the cytotoxic fluid will cause an abortion. So you have to remove the hydrosalpinx. Internet is and adenomyosis, again, do an MRI and find out. You can give an GnRH agonist or surgical excision of the adenomyoma. So hysteroscopy in recurrent IVF failure, you can do a multi-center. So there was this study, outpatient, where they showed that whether do you want to do a hysteroscopy in all the patients. So this, that patients with something seen on the 3D sonography, or if there is an issue in the uterus, then only an hysteroscopy done in an IVF patient will benefit the patient in improving the live birth rate. Otherwise, just you're trying to do it is not going to help. Endometrial injury, we do a lot when the endometrium doesn't grow in the first or the second cycle. There have been proposed for improving endometrial, several hypotheses. It facilitates endometrial desudalization. So scratching, you can do it with the EB, like we do it with a small EB curate as an OPD procedure. And we scratch on the anterior wall, posterior wall, and the lateral walls. Injury leads to healing with activations of the immune response with cytokines and interleukins, growth factor. It slows endometrial maturation to improve the synchronicity. So you can try. So now there are many people say, when do I do? Should I do it on the day I retrieve the eggs? Should I do the about 2 months before? So there was this study wherein 1,000 women were there, and they showed that if you scratch on the previous cycle on day 21 or on a day 2 of this cycle where you're stimulating, which will give you the better results. So what the moderate quality evidence show that previous cycle on the day 21, if you scratch the endometrium, you'll have a better results in having a live birth rate. And what about the endometrial injury to overcome the recurrent? Again, this was another study wherein 2,000 participants were there. The evidence is strongly in favor of inducing local endometrial injury in the preceding cycle of ovarian stimulation to improve the pregnancy. So like I said, in the previous cycle, day 21, do the endometrial injury. You can even use an IUI catheter and cause a little bit of injury on the walls, but I prefer an EB catheter. Endometrial scratching in women with implantation failure after the first IVF cycle. So there are a lot of studies showing that this does help a lot. So I feel when you do not have the endometrial thickness growing, you should go ahead and do a scratching. Cellular mediators and drugs to improve the endometrial receptivity. So this is another peripheral blood mononuclear cells were removed in the patient and they were injected intrauterine, but they did not show much great results. So I don't think intrauterine administration may be an effective approach to improve embryo implantation in patients with repeated IVF failure. It's insufficient evidence. So I would say we shouldn't go ahead and do that. What about using high natural killer cells? So this is good, wherein they had a patients, about 295 cases for the third IVF failure, wherein 81 women with natural killer cell assay treated with IV immunoglobulin, they gave about 400 mg per kg on the day of the EP. What did they say? If the natural killer cells were high, the levels were high, then only IV immunoglobulin helped these patients. Otherwise, it did not help. So IV immunoglobulin treatment enhances pregnancy rate in RIF patients with high natural killer cells, but does not affect IVF outcome in patients with normal killer cells. So whoever has a higher natural killer cells, yes, it will help with those patients. So role of immunotherapy will be if do a natural killer cells test and then only decide to whether you want to administer it or not. GCSF, very commonly now, everybody uses GCSF, ref, light and center, even in an IUI case. Yes, as you know, a lot of studies have done, but there is still, the evidence is not so much for it, but there is no harm trying injecting. So you can inject on a day 7 or a day 11 and repeat the sonography. If it's more than 6 mm, then you should give the GCSF. If it's very thin, 4 or 5 mm, GCSF is not going to help. So there is insufficient evidence on administration of GCSF. What about the platelet-rich PRP? You hear continuously nowadays a lot of papers, people talking about PRP administration. Yes, so there's a very small study which shows that, intrauterine infusion of 0.5 ml of platelet-rich plasma that contain platelets about 5 times more than the platelets than the peripheral blood sample, and was performed 48 hours before transferring the blastocyst. 18 patients were pregnant with 1 early miscarriage and 1 molar pregnancies, and 16 clinical pregnancy were recorded. So this shows that a PRP will help. Yes, and even we use PRP in our center. It does improve the endometrial thickness in few patients. What about intrauterine injection of HCG? So you can even inject HCG 5000 IU inside the uterus a day prior to ET. So today you've decided you want to do the ET on Thursday, Wednesday, call the patient, inject 500 IU of HCG. Like, we do not get the 500 IU, you get 2000 IU minimum. People inject mostly 2000 IU of HCG. What about immunotherapy with paternal lymphocytes for recurrent? So in this, they had tried to remove the blood from the husband and injects little intradermally, which, this is out because there were a lot of reactions and nobody does that anymore. And does intralipid. So intralipid infusion, most of the patients, we do inject intralipids because that is easily available. You get it ready. It's like just high protein. You have to be careful. There is no reaction. First 10 minutes, give it slow, then you can complete it. So here the conclusion was not so much with intralipids, but yes, in our practice, we do use intralipids and they have given us results. So intralipid infusion for patients with RIF with elevated natural killer cell does not improve live birth rates. Moreover, despite the low cost of the intervention, it is not cost effective with the majority of the patients with RPL. There is insufficient evidence for what is the ASRM again says that no, it is not that recommended for IV fat emulsions for infertile women. But like I said, yes, sometimes, when you have 3 attempts fail, good embryos, lining is good, you do not have any answers, you can try intralipid. What about the low molecular weight heparin? So we do not give low molecular weight heparin to all the patients. Like most of the IVF centers I've seen, when they come, they are all on low molecular weight heparin. But here, only if there is recurrent implantation failure or she is APLA positive, then only we give them a low dose, that is 1 mg per kg body weight. So yes, they have shown that it does help in low molecular weight, in implantation rate and clinical pregnancy rate. So there is no harm in giving low molecular weight heparin and ecosprin. So you can continue with that. What about the treatment for defective embryonic development? So oocyte quality, that is really important in PCOS patients, especially. I prefer giving them a recombinant FSH, which will improve the quality of the oocytes for the first 7 days, and then maybe add an HMG later. Treatment for high DFI, you give them antioxidants, then start them on their whatever the male factor. Give them 2-3 months of antioxidants. The count is low. IMSI if required when the count is low. Assisted hatching if the female is more than 37 years old. Autologous endometrial co-culture, blastocyst transfer, sequential transfers do help. When you put in the best day 3 embryo, then culture it to a blastocyst and transfer again on a day 5. PGS, if there is, you want to know she's more than 38, 39 years old, is there any abnormality in the embryo, you can go ahead with a PGS, time-lapse monitoring. Improving embryo, good embryo transfer technique is very important. Embryo glue and freeze-all policy. So treatment of poor oocyte quality. So correction. So check out what was the previous stimulation. What did they give? What was the oocyte? How many oocytes did they give? Change the protocol if required. Few studies have suggested addition of LH is beneficial in low hyporesponders in women in more than 35 years old. Women with endometriosis, use of Depo GnRH agonist 3 to 6 months prior to stimulation also have improved pregnancy rate. So have patience. Think about if it's an endometriosis, give an GnRH agonist about 3 to 6 months before. In patients with a low, the AMH is low, when they're diminished ovarian reserve, give them an LH extra with an FSH. That will help us improve our oocyte quality. What about the sperm DNA fragmentation? When we get a DFI which is low, or you feel that they've shown poor quality, you use antioxidants. You can even do a testicular. Sometimes what we do if the DFI is bad, and I do half with the ejaculate sperm and half with the biopsy, and we do the ICSI if required, and IMSI. What about ICSI is the most important because the IVF is not going to help. ICSI or IMSI. IMSI procedure is valuable option for patients. That was previously in 2013, but now the ASRM again has changed and said IMSI does not have any role. So this is an old paper, but otherwise now IMSI is, they do not believe in IMSI. What about the laser hatching? So in patients with advanced age, the cumulative pregnancy rate and recurrent implantation failure, similar test and control, all patients with frozen thawed embryos, the rates was statistically significantly higher in the test group. So if she's 37 years old with recurrent implantation failure, I would prefer doing a laser hatching on these patients, and that has improved slightly the live birth rate. In FET, when there's frozen embryos and 38 years, about 38 years old. So like I said, laser hatching improves the outcome of frozen thawed embryos transfer when performed before transfer on embryo that were allowed to cleave. What about ICSI? So assisted hatching does appear to offer a significantly increased chances of achieving a clinical pregnancy. The extent to which it may so that reach the statistical significance. So like I said, anybody more than 38 years old and frozen embryos, do a laser hatching. Not co-cultures, we do not use. Is tubal? No, we do not do that. And endometrial injury, like I said, that is, so there was one, when you transfer a good quality embryo, endometrial injury have shown to improve the clinical pregnancy rate. So cleavage stage versus blastocyst. Everybody talks about a blastocyst embryo. Yes, it depends upon the embryo quality, how many failures. If there are failures, I would say let the embryos go to a blast. Think about PGS, think about sequential transfer, think about embryo glue. You can give these options to the patients because the patient needs what next, ma'am. They do not want you to do the same thing. She might say, what after this, what do I do? So you have to give them options. That's the way that even they know that you're trying something new and you're not giving up on her. So you can even try with the embryo glue, has given results. Pre-implanted genetic screening. So we can just do, so there is, with nowadays there are these co-cultures, just the media from the embryo, around media, that is taken and sent for testing instead of doing an invasive biopsy and getting the answer. So that is another year they showed that PGS has not helped much in patients who just had RIF, but yes, when they were more than 38, 39 years old or very low sperm count, that time the PGS has helped. Can time-lapse parameters predict embryo? So what happens? The available studies are too small or firm conclusions to draw that the predicted value of time-lapse. So we need more patients to use, more doctors having the time-lapse machine, which will help us, whether will that help our patients or to know which embryo is better. Embryo transfer technique, like I said, many people do not talk about this, which is the most important. See, embryo transfer is the final and the most important step. I have done everything to get the best embryo. I've given an amazing stimulation. I've got good oocyte this cycle. But if I have not transferred the embryo in the right place, I'm not going to get the pregnancies. For patients with difficult transfer, the pregnancy rate was 22.3% compared with 31.6% for patients with easy transfer. It's always wise to perform a trial mock embryo transfer, preferably during the initial patient visit. If you think it's going to be tough, do a mock transfer first. If a soft catheter cannot be negotiated through the cervical canal, use a stiffer catheter with a malleable inner stellate. Cervical dilatation or hysteroscopy, cervical shaving should be considered in women with a trial transfer is unsuccessful. If you feel it was very tough while you were doing a mock transfer, please go ahead with a hysteroscopy and then postpone it for the next month. The transfer should be so simple that it should be, patient should not even realize that you have gone inside the uterus, left the embryo and come. They are going to give you good results. So there was this study wherein when you put in the catheter, if there was blood on the outer catheter or the inner sheath. So if there was, so to compare what was the conclusion, that cervical traction and the blood on the outer catheter do not compromise the clinical birth rate. But if there is blood in the inner catheter, yes, the pregnancy rate was down. So when you transfer, you go till the cervix, the outer, then you shift inside the inner catheter, the inner line. And if there was blood on the inner, there is a problem in the pregnancy rate. What about the role of embryo glue? Like I said, people are using a modest increase in the clinical pregnancy rate, but it was not found to be clinically significant. Further studies with large populations are required to prove the possible beneficial effect of embryo glue. So we are kind of trying to get our patients with our embryologists using embryo glue to get our results. And let's see, after maybe 2 years, we'll get our paper. Adherence compound in embryo transfer media. So people are trying to use like fibrinogens to improve the chances that the embryos implant. Revisiting the management of recurrence. So, we have to find freeze-all and fresh transfer. Of course, we all know pregnancy rates are better with freeze-all policy. Now, very few people, fresh transfers are done only if they are about a very diminished ovarian reserve, where they got good quality embryos, the progesterone is less than 1.2, lining is very good. Only in these cases, we do fresh transfer. Otherwise, we freeze all the embryos. Multifactorial treatment options. Psychological assistance is the most important. Three failures, patient has lost, given up hopes. You have to make sure tender, loving care for the patient. You have to be with her, talk to her. It's not like, oh, you failed, I don't know what's the reason. Explain, tell her you're with her throughout the journey and you will try to give her the results. We can go give them other options, but do not just leave it. You have to talk to the patients. What is the next step? What can we do? What do we do together? Lifestyle changes. If she's obese, tell her to reduce weight. No smoking, no alcohol consumption. Treatments for endocrinological disorders. Make sure the thyroid is normal, diabetes is under control, obesity, and tailoring the stimulation protocol is very important. You have to make sure the stimulation is given, change the stimulation, add different drugs, go for the recombinant if required, and make sure the oocyte quality is improved. So what about IUCD was used in implantation to, in these patients, but that also did not give that great result. So what is my take home message? There is yet no universally accepted definition for RIF. Etiology underlying recurrent implantation failure is complex and cannot be attributed to a single abnormality. A multidisciplinary approach should be adopted in the management of couples with RIF, which involves an experienced fertility specialist, senior embryologist, reproductive surgeon, and a counselor. Remember, if a embryologist is not talking to the fertility specialist, or fertility specialist is not having any talk with the embryologist, you will never get the result. It's a teamwork. It's a complete teamwork. A good embryologist, a good nurse who's going to show you when you transfer the embryo, holding the sonography machine, you doing the pickup rightly, getting the oocytes and stimulation done well, that is going to give you the result. And a counselor who's going to support her mentally throughout the journey. So this is always a teamwork. It's not because of you or because of the embryologist you're getting the result. Do a teamwork, discuss the cases when there are failures. Sit down one day with your colleague, with the embryologist. What is the reason of the failure? What do you think we should change? Was it the oocyte? Was it the sperm or the embryo? Or was it a transfer? Everything has to be discussed, and then next cycle you have to change. Empirical therapy should be used whenever possible, be considered only in the setting of carefully conducted clinical trials. Anything new when you're trying, try what is evidence-based. What is we've shown what is the evidence. We won't just add too much of medicine in these recurrent implantation failures. They're already exhausted with so much of. Already you're going to give them every day, low dose heparin, plus the steroid maybe, plus progesterone. I've seen people giving 3 progesterone. So try to reduce. Do not over add. That's not going to help. If you're giving 1 progesterone, adding 3 progesterones are not going to help improving the results. So make sure do not add too much medicines of different, companies. Instead of that, make sure you give them what is required and the right amount of treatment. Thank you.
Thank you, ma'am. Thank you very much for that excellent presentation. Yes, so all the points were covered very beautifully. We will wait for the any additional questions, and then we will go for the next talk. Before that, just one question from me, madam. If the case is idiopathic where cause is not known, it is not ascertained. So what are the first 3-4 steps you would always do as far as the management is concerned in recurrent implantation failure?
When it is idiopathic, you've done everything. You don't know what is the reason. If the embryos are good, I feel scratching has helped a lot of my patients. Just simple, just previous cycle, I do a scratching, make sure the embryo transfer. The person who is showing me, if I was not very happy last time, the nurse showed me, I will use a Labotic catheter, which is very soft, atraumatic. Make sure the person knows how to show me rightly and transfer the embryos back. Like I said, or go to a blastocyst. If I had done a cleavage stage, day 3 embryo transfer, maybe I go to a blastocyst, or I would do a sequential transfer.
Okay, right, ma'am. Thank you very much. Currently, we don't have any questions. So as and when we receive the questions, I'll definitely read out those questions to you. Thank you very much.
Thank you.
We will, yes, ma'am. We will go to our next presentation regarding egg preservation. Over to you, ma'am. Thank you very much.
Thank you so much, Dr. Prachi. Hi, I am Dr. Anuranjita, consultant at Apollo Fertility, Navi Mumbai. My topic is very apt for today's world. I'm going to be really short and sweet, and it is very apt for today's world. So I want to touch on the aspect of something known as the egg freezing or the egg preservation or egg cryopreservation. It is all the same thing. So coming to what is egg preservation, also known as Oocyte Cryopreservation, is a great advancement in the technology allowing women to preserve their fertility and their eggs. These eggs, once removed from the body, are frozen using special techniques and can be used to make babies by the process of IVF when the woman desires. Who are the women? One second. Yes. So who are now the next question which arises is who are the women who should go in for the egg freezing? So oocyte cryopreservation is optimum treatment for the following group of women. The first category includes women diagnosed with cancer who have not yet begun chemotherapy or radiotherapy. Chemotherapy and radiotherapy, we all know, are toxic for the oocytes, leaving few, if any, viable eggs. Egg freezing offers women with cancer the chance to preserve their eggs so that they can have children later in the future. So this is a very important, indication where we go ahead with something known as the oocyte freezing, because we have to, consider oocyte freezing, especially cancer in young females, because a lot of females are developing breast cancers and a lot of cancers at a very early stage. So all these chemotherapeutic drugs which we use, they completely destroy the eggs. So later on, if they wish to have, and the cancer survival because of the treatment facilities available has definitely prolonged the life, and we have a lot of cancer survivors. So later on, if they are willing to have their own child, it becomes very difficult for us to give them their own genetic child because of the toxic drugs which have already destroyed the eggs. So yes, egg preservation before starting the chemotherapy or the radiotherapy should be considered in women who are suffering from cancer. So second category of women includes women who would like to preserve their future ability to have children, either because they do not yet have a partner or for other personal or medical reasons. One thing I would like to highlight here is why this egg preservation has become very famous and why this is an upcoming topic. Is, one thing which we have to remember is all women, it's not only you, me, or all the women have a biological clock ticking in them. What do I mean by a biological clock ticking in them is that women are always born with a certain number of eggs, like, which keep on declining with age. And once all the eggs get over, you attain menopause. So after 30 years, this decline in both the quality as well as the quantity occurs at a very rapid pace. That's why this whole concept of egg preservation has come into being. Because as you age, it becomes, see, if you freeze your eggs at an early age, suppose when you're 25, 26, 28, you have like the best quality of eggs at that time. So with that eggs, and suppose you plan to get married, many reasons, many females have become career oriented, and because of a lot of social issues, personal issues, you're not getting a boy, you're not getting a love of your life, so you get married at 37 years, and by that time we see really poor quality eggs. So if you have frozen your eggs at an early stage, we can use those eggs to give you a healthy baby. That is why this whole concept of egg preservation is important, because of the biological clock in women. As you age, the quality as well as the quantity declines. So the third category of women includes women with a family history of early menopause can also opt for fertility preservation. With egg freezing, they will have frozen a store of eggs in the likelihood that their eggs are depleted at an early age. Egg freezing can also be beneficial for women who, for the purpose of education, career, or other reasons, desire to postpone childbearing. Freezing eggs at an early age may ensure a better chance for a future pregnancy, because we have a lot of patients who get married later on in life, suppose 35, 36 years of age, and then they immediately do not want to have a child, and they come at 37, 38, 39 years of age. So it becomes very difficult. It is always like, even if a patient who has a low egg reserve, same. But if a female is 30 years old and the other female is 38 years old with the same egg number and the egg count, it becomes easier for us to give a pregnancy to a 30-year-old than to a 38 or a 39-year-old, simply because of the fact that the quality of eggs has declined. Though the number is the same in these two females, if you consider 30 and a 38 years, suppose they have 5 eggs and the 38-year-old also has 5 eggs. But then yes, a 30-year-old, the quality of eggs are going to be definitely better. So giving them, a healthy pregnancy becomes much easier even with an IVF as compared to a 38 or a 39 years old. So this concept of egg freezing is there, so that you just freeze your eggs. Whenever you're ready to have a child, even after 10 years of marriage, you have your eggs which were frozen at 25 years of age, which gives you a better quality of pregnancy and better chance of pregnancy. So what is the process of taking out the eggs for freezing? It is similar to the normal IVF which we do, but instead of making the embryos, because the techniques initially we do not have this method, and we used to go ahead with this oocyte preservation was not available. But then because of the recent advances which have taken place in the IVF field, we are able to freeze the oocytes and retrieve them of the similar quality which were frozen earlier. So what is the process of egg freezing? The egg retrieval process for oocyte cryopreservation is the same as that for any IVF. This includes 10 to 15 days of hormonal injections depending upon your body's response that stimulates the ovaries to grow multiple eggs. What happens in a natural cycle is, if you see that, every cycle, day 2 or day 3, a cohort of follicles come in. Like if the patient is young, then they have 10 and 10 eggs minimum, out of which around 14th or the 15th day, one egg grows. If you have relation during that time, you get pregnant, and otherwise it atrophies. Rest of the eggs also atrophy in that cycle. So in IVF or in oocyte freezing, we come out of physiology. We give you high doses of hormonal injections, and please let me make it very sure, we just take out the eggs of that particular cycle. It does not affect your subsequent cycles, because many patients ask me, if you take out my eggs, what happens? But it is only during that cycle, the eggs which are present, we are going to take out those eggs. We are not going to touch upon any other eggs which are coming in the future cycles. And these hormonal injections, when given in high doses later on, do not have any consequences on the oocytes, on the ovaries, or on the person as a whole. So these are completely safe methods which provides you a better chance for future fertility. So the eggs are subsequently removed from the body by a transvaginal route. There are no cuts. It's a daycare procedure. Once you're ready, once all the eggs have grown, because we are planning to go for multiple eggs so that you don't have to go through these cycles again and again. So that is why we target all the eggs of that particular cycle by giving hormonal injections. And these are very safe method. We go through a transvaginal route. It is a daycare procedure. You come at 9, you can go by 2. The egg taking out the eggs particularly takes hardly to 10 to 15 minutes, and it is a totally painless procedure because we have started it doing under anesthesia. So the procedure is usually conducted under anesthesia, which makes it a totally painless procedure. The egg collected are then immediately frozen. So how are the eggs frozen? The egg is the largest cell in the human body and contain high amount of water. So when the eggs get frozen, the ice crystals that form can destroy the integrity of the cells. So to prevent this, the egg must be dehydrated prior to freezing. So this is done by using cryoprotectants, which replace most of the water within the cell and inhibit the formation of ice crystals. Then these eggs are stored as long as required in the IVF lab. So how are these eggs used later on to make the embryos? When the woman desires to have a baby, she is put on medicines to prepare her uterus and her body to receive the embryo. Then the eggs are thawed, and a special fertilization procedure is performed by the embryologist, which is known as the intracytoplasmic sperm injection. Nowadays, we do ICSI, which is in short form ICSI. This technique is also called as ICSI and is also used in IVF. So are the babies, the most important question which runs in everybody's mind is, are the babies formed from frozen eggs normal? Yes, definitely. 2 recent studies showed that the rate of birth defects and chromosomal defects when using cryopreserved oocyte is consistent with that of a natural pregnancy or a conception. This is little away from the topic, but then we also have an option of semen freezing. The indication remains the same as that of females. Similar to egg freezing, there is something known as the semen freezing, which can also be done, especially in cancer patients undergoing radio or chemotherapy, because the chemotoxic drugs destroys the sperms and they may become infertile later on in life. So if they want to harbor their own child, the same facility, but then definitely males do not have to take injections. They can just, give the semen by masturbation, and that can be frozen. So that is all from my side about semen freezing and oocyte freezing. I hope I gave an insight about what is oocyte freezing and why do we freeze it, what is the biological clock, and later on in patients, how can they harbor their own child, have their own child. Thank you so much.
Thank you, ma'am. Thank you very much. It was a very nice presentation. A lot of insights. Yes. One question, ma'am. How long we can preserve these eggs? Is there
10 to
any
15 years.
study?
That's, 10 to 12 years.
10 to 12 years.
Yes,
And ma'am,
yes.
how frequently women are coming? How common this procedure is compared to, say, 5 years back?
It is very honestly, it is still getting into, people that there is something known as an oocyte freezing. But yes, in OPDs, at least 1 to 2 per month will be definitely seen.
Yes, so that is definitely a good amount.
Yeah, it is reaching this whole concept of oocyte freezing and harboring their, having their own children later on is definitely, we already have a cancer, a patient, 19-year-old for whom we are planning to freeze the oocytes because she's going to be started on cancer therapy. So
Okay.
yes, patients are coming, even cancer patients, because cancer is becoming more common in young females and cancer survivors are more. So, this is one thing which comes into play and helps you out to have your own child later on.
Right, ma'am. So yes, thank you very much. Ma'am, we don't have any additional questions from the audiences. So thank you very much for your presentation. And also thank you, Nikita ma'am. Thank you for that excellent presentation. Thank you very much.
Thank you.